Yeah, so the studies that we included in the review, they did investigated different concentrations of sucrose, and we combined them all just to have the amount of data or a better quality and strength of evidence to provide some results with the review. But yes, the studies included 10% sucrose, 24% sucrose. Some included even 50% sucrose, which is way too high. And what we see in most of the clinical protocols and clinical practice guidelines available, such as the one by the American Academy of Pediatrics, is that sucrose 24% is the most safe and indicated concentration. In terms of dose, we also see a large variation in terms of volume. So we have some studies that administer zero point 0.1 ml of sucrose, others administer 1 ml sucrose. We do have some publications, again, some hospitals, protocols, some clinical practice guidelines that recommend the dose based on the infant's age, gestational age, sometimes based on their weight. So there's a huge variation in there, but we know that very small amounts like zero point 0.1, zero point 0.5 mLs are enough to provide analgesic effects in procedures like heel lancing, venipuncture, and IM injections. So those the smaller amounts should be used, and if needed, clinicians can repeat the dose during the procedure. They can give additional drops of sucrose during the procedure if the baby gets agitated, starts crying, and demonstrating signs of pain. And I think in terms of the time of administration, we recommend giving sucrose 2 minutes prior to the procedure. So it takes around 2 minutes for the sucrose to stimulate the endogenous opioid system and to actually provide analgesia. So we recommend 2 minutes before the procedure, administer a few drops, zero point 0.1, zero point 0.5 ml of sucrose directly on the baby's tongue. And after 2 minutes, you can start the procedure and again give a few drops if we need a rescue dose, for example. We do have evidence that sucrose and pacifier have synergistic effects, so they work better when they are offered in combination. So, if the baby has the ability to suck and to coordinate sucking, to coordinate breathing while sucking, we can add some drops of sucrose into the baby's mouth and follow by a pacifier. So the baby needs to be sucking the pacifier effectively and rhythmically throughout the painful procedure for better analgesic effects. We also have evidence in terms of other strategies like breastfeeding, skin to skin care, facilitated tucking for these types of procedures. Again, venipuncture, heel lancing, IM injections. And we also should be using these other interventions. I think they all have their different places and their different recommendations depending on the setting. So I would recommend breastfeeding and skin to skin care to be considered first if the baby is able to be placed on their parent's chest, if the baby is able to be breastfed. If not, we can use sucrose and non-nutritive sucking. We can even use facilitated tucking, which is putting the baby on a kind of an intrauterus position and holding the baby on its side with the hands comforting or supporting the head and the limbs. And we can use facilitated tucking with sucrose. So I would try this, what we call parent-led strategies with breastfeeding and skin to skin care. But if the baby is not able to be positioned in this types of interventions, if the baby is not able to support manipulation, like being taken from their bed or their incubator and put in the holds of their parents, I would recommend sucrose or facilitated tucking.